Noir Plasma Chrome Bleed. Unlocking knowledge, inspiring innovation, empowering curious minds.
This website makes learning so easy. I found all my resources here. This website makes learning so easy. I found all my resources here.
Spongy lattice. Optimizes microanatomy. Advanced biomechanical analysis stress distribution. This governs clinical dynamics and bone remodeling. Cancellous bone constitutes a highly porous osseous tissue. It is located within the interior of bones, long bones. This macro-micro architecture helps distribute localized stresses. Long bone epiphyses are found in the appendicular skeleton. They form a highly porous, anisotropic trabecular lattice. This region is richly supplied by vessels and dense sensory nerves. Vertebral bodies are irregular bones. They contain columnar trabecular rods. This matrix is extensively vascularized. Sensory nerves are highly abundant here. The pelvic bones and ribs are classified as flat and irregular bones. Inside, a dense trabecular network is surrounded by a thin cortical shell. This network serves as a skeleton. Bones are categorized by their shape. Long bones feature a central diaphysis. This transitions into the epiphysis. There, the growth plate aids growth. It disappears by age 20.
Pressure epiphyses are articular. They directly transmit body weight. Examples include the head of the femur or the lower end of the radius.
Traction epiphyses are non-articular. They serve as sites for major muscle attachments, which exert tensile traction on the bone. Atavistic epiphyses are bones that have fused in humans, such as the coracoid process. Aberrant epiphyses are non-constant developmental variations, like at the first metacarpal head. Bone's layout is determined by its composition. The organic phase is composed of elastic collagen fibers. The inorganic phase is responsible for its hardness. Cancellous bone houses a dynamic cellular network. Osteoblasts secrete the unmineralized, some trap themselves, becoming osteocytes. This continuous cycle drives metabolic remodeling. Osteocytes reside within small cavities called lacunae. They communicate through long, branching processes. This network functions as the primary mechanosensory system. Osteocytes transduce forces. Osteoclasts resorb bone. They secrete hydrochloric acid to dissolve crystals. Bone marrow fills the cavities of cancellous bone. It creates a vital environment for blood cell creation. In adults, it can revert to red marrow. This process restores its full capacity. Cancellous bone has higher metabolic activity. Over 30% is remodeled annually. This surface serves as the primary site for rapid mineral exchange. Systemic hormones act on these cells to regulate recruitment. Denosumab substantially decreases bone turnover. This rapid remodeling prevents advanced crystal maturage than compact bone.
Cancellous bone mineral displays a lower Kp ratio. This younger, less mature phase is more soluble, allowing the skeleton to respond to calcium demands, balancing support with responsiveness.
At the sub-micrometer scale, individual trabecula are composed of parallel lamellae. Successive remodeling events leave behind a patchwork of hemiostions. BMUs create cylindrical Haversian systems.
In cancellous bone, however, BMUs deposit bone in crescent-shaped hemiostions. These cement lines contain significantly fewer nanochannels than the adjacent lamellar. Let's analyze key bone histomorphometric parameters. Young cohorts show higher median BSU profile length. Profiles show decreased perimeter, correlating with frag-trabecular packets. Young cohorts show a healthy, dense bone matrix. In postmenopausal bone, fragmentation increases. This expands the brittle interface exponentially. Decreased wall thickness drives fracture risk.
How do these changes influence macroscale behavior? Decreased BSU length and perimeter represent physical fragmentation, creating a dense network of weak interfaces.
These interfaces act as sites of stress concentration. Microcracks propagate along these boundaries. This causes catastrophic failure.
When subjected to compressive loading, cancellous bone exhibits a linear elastic phase. Here, individual trabecular struts deform. During the plateau phase, stress remains nearly constant. Trabecular plates and rods undergo progressive failure. Densification begins as the struts make. At this point, the internal stress rises rapidly. Under tensile loading, cancellous bone behaves as a brittle material. This explains why avulsion fractures can be caused by minor trauma. In low-density regions, trabeculae form rods. The modulus scales quadratically with density. At higher densities, plates dominate. These plates deform through bending. Modulus scales cubically. In regions like the human tibia, trabeculae form a columnar architecture. These columns deform through axial compression, resulting in a linear scaling relationship. Because of this columnar arrangement, oriented cancellous bone is highly anisotropic transverse direction. In contrast, twice as strong in regions in compression as in tension.
We begin by isolating a single trabecular strut from the femoral head. Individual trabecula are mounted for microtensile tests. The apparent modulus reaches 8.8 jar. Yielding begins at 30 MPa as damage accumulates. We are testing a human vertebral body specimen. The apparent modulus averages 374 megapascals. Inverse FEM, inverse M optimizes the damage properties.
Analyzing a single vertebral trabecular strut. The tissue modulus reaches nearly 10 gigapascals. Wet buckling stress measures 11.38. Stress concentrates around the lacunes. Evaluate ultrasonic propagation. A critical distinction exists between bulk and tissue modulus. While porosity reduces bulk stiffness, solid tissue is significantly harder, making cancellous bone more viscous and energy absorbent. This represents a functional shift from a stiff, elastic material to a soft, viscoelastic. This allows the network to absorb and dissipate energy while retaining its load-bearing capacity. Normally, bone remodeling is balanced. Osteoporosis disrupts this equilibrium. Resorption exceeds formation, causing perforation.
In osteoporosis, bone volume fraction drastically decreases. This breakdown reduces overall bulk apparent stiffness. The bone loses its ultimate compressive strength.
In osteoporosis, the trabecular number decreases significantly. This indicates the complete physical elimination and deletion of individual trabeculae. In osteoporosis, trabecular separation is significantly increased. This increases the effective buckling length of remaining vertical columns. In osteoporosis, horizontal connectivity is preferentially lost. This removes critical transverse bracing elements, predisposing vertical columns to Euler buckling. This decay was modeled as a plate-to-rod transition. SMI suggested a shift from plates to thin rods. However, modern analyses show that SMI is heavily biased. Decreasing bone volume causes the index to artificially inflate. Osteoporotic bone loss is characterized by physical perforation. This results in a complex mixture of hybrid shapes. How does this influence damage? Plate-like trabecula support the bulk of mechanical loads, while rods act as links to distransfer stress. Diabetic bones fail to form these protective microcracks. This explains the elevated fracture risk in T2DM. In reconstructive orthopedics, bone grafting restores skeletal volume. Following implantation, necrotic debris stimulates chemotaxis, recruiting cells to begin the healing process.
Cells migrate along the graft. Molecules stimulate host stem cells. They differentiate into active osteoblasts. The integrated graft undergoes dynamic remodeling.
Autogenous bone grafts are the gold standard. They provide osteoconductive, osteogenic properties. This occurs by creeping substitution. However, kinetics differ between cancellous and cortical bone. Highly porous cancellous autografts allow for rapid revascularization, initiating an apposition first creeping substitution process. Osteoclasts later resorb the dead cores. Dense cortical grafts show delayed revascularization. Osteoclasts must first resorb the bone matrix. This causes a transient reduction in strength.
BM shows impressive profiles. It features a strong compressive profile. Cytotoxicity is low with high viability. Expect over 50% mass loss in 7 days. Rich collagen ensures superior cell adhesion.
To avoid donor site morbidity, surgeons use allografts or DBM. Cytic extraction leaves a scaffold of type I collagen. Cancellous DBM mimics the native matrix, enhancing cell adhesion.
Cancellous DBM shows superior biocompatibility, however, 50% of its mass within 7 days. Cortical DBM retains much higher compressive strength, making it ideal for load-bearing.
Differences are critical when selecting surgical techniques. Granules are introduced to fill void spaces. Traditional spongioplasty is associated with flattening. Distortion inhibits capillary ingress. Cancellous bone is a highly specialized, structurally optimized biomaterial. Its porous lattice allows for compliance metabolic remodeling, making it vital for hematopoiesis. Cancellous bone is vulnerable to degradation. Its kinetics make it effective for regeneration. Understanding this is essential for implants and optimizing treatments for metabolic diseases.
This website makes learning so easy. I found all my resources here. This website makes learning so easy. I found all my resources here.